just moving things around, get things circulating. But the earlier you can get them up, the better. Pain management, you have to control pain, right? If you're in pain or, in any discomfort, then you don't really want to move. You'd rather just sit still. You don't want to do anything that's going to get the pain any worse. So making sure they have good pain management. Epidurals now have, or spinals have 24 hours in them. So when they do the spinal for a repeat C-section or a scheduled section, they give that injection and she's good for 24 hours. And after that 24-hour mark, they can usually switch over to like PO pain meds, like Percocet or just Motrin. Some still have PCA pumps, depending on what type of stent they get. Okay. If they don't get that spinal with the 24-hour pain control, they'll come out of the OR with a PCA pump. All right, emotional care. In addition to the physical changes, the birth of a newborn brings on many emotional and relationship changes as well. Okay, for the mom, transition to motherhood, lots of hormonal changes. There's a lot of hormone shifts that happen after the baby's born. Changes in body image. Sometimes it's hard. They still look pregnant. Some may think that they're going to have a nice flat tummy after the baby's born, but 10 years later, and that's not the case. So certainly is not going to be the case after the baby's born. Psychological acceptance of herself as a mother figure, especially if it's her first baby, it's going to be like a whole new experience, right? Fluctuating hormones affect mood, cause early elation by mild depression, and we'll talk more about baby blues and postpartum depression in chapter 10. Those baby blues usually peak around day 5, and they're very normal for moms to have. All right, Rubin's psychological adaptation of the purpurium and related nursing interventions. Very lightly talk about this. It kind of talks about the phases that the mom goes through after the baby's born, and how, right after the baby's born, there's her focus really on her, pretty much on herself, right? Wanting to talk about the delivery, wants to eat. There's time frames that are included in this that aren't really appropriate now, because at best you're in the hospital for 4 hours, right? Even with a C-section, you're 3 to 5 days. Whereas back when this was developed, people were in the hospital for a full week. It kind of talks about when a good time is for teaching, and that would be, a good time for teaching about infant care, a little more concerned for how to take caring for me. Real for just some. But we have to be on time. I can't be the only one that has the rules. I know. I don't get in trouble. I don't follow the rules. So yeah, and that lets go for kind of giving up what they thought the baby was going to look like, or a gender baby, what they thought what they thought the baby was going to look like, or a gender baby, what they thought the baby was going to be, and accepting. It was also called baby blues. Conflicting feelings of joy, emotional letdown in the first weeks of life. And the students have teary moments. Guys, they respond to assume the role of free moments. Guys, they respond to assume the role of mom and care for the baby. Postpartum evaluation for fatigue, which, nobody's sleeping that well at the end of pregnancy anyway. And chances are you probably had a long labor, probably didn't get much rest, so you're going into it pretty tired. And a lot of times now moms have to work right up until the time they have the baby. So you're not even getting where the baby's born. So making sure that they're getting rest, making sure they have help at home. or once they go home, all of that. Right, becoming a parent requires learning new roles and expectations. It's an adjustment period, whether you have one child or several children. As I always say, adding a new person into the house is going to be disruptive for everybody. Okay. Demands of parenthood affect communication between partners and children, distract from the relationship at times. And that may be something that we've all experienced, right? If you have kids, you get to a point where it's like you're just tag teaming and trying to get through the day. Who needs to be where, when, who needs what, you know, you kind of lose the relationship that you have with your significant other. But, you know, maintaining open communication and making sure everybody's needs are met is going to be important. All right, fathers typically display intense interest in the child. They go through 4 phases of adjustment, having expectations and personal intentions, what their expectations are of the birth and care for the baby postpartum, confronting reality and overcoming frustrations. It might be hard for them in the beginning because mom has to do a lot, especially if she's breastfeeding, right? They can't help feed the baby unless mom is either bottle feeding or pumping and giving the baby a bottle of milk. So they may feel a little bit left out in some aspects. Creating one's own personal father role and then reaping the rewards of fatherhood. And adjustment is facilitated by involvement in the newborn's care. Father should be included in instructions and teaching, or whoever, the spouse, the support person, whoever's going to be helping that mom should be included in any directions or education that you're providing. Siblings' influence depends on the age and developmental level of the child. Toddlers may respond with anger. They don't want to share their moms. Toddlers don't like to share. Preschool children may look at and talk about the infant, but they're kind of in their own little environment. Older children they like to be helpful to an extent. I remember when I had my fourth one, my oldest one, I used to be like, can you just hold her for like a minute? Like just hold the pacifier or go give her the pacifier. And so it got to a point where I have to do everything around here. Everything. Like, So they like to help, but then it gets old. It gets old fast. Grandparents we talked about in the past, in chapter 4, it's going to depend on the expectation of the relationship, right? If you're expecting that grandma and grandpa are going to come over and help all the time, and grandma and grandpa are like, nope, that's okay. Or vice versa, grandma and grandpa don't, or they want to come over all the time and help, and you're like, stay away, you can come right. Then there can be some conflict. All right, grieving parents, it's hard if there's grieving parents. There's nothing you say is necessarily going to make it feel better, but being there to support them, listen, there's no magic words that are going to make them feel better. Therapeutic communication, such as open-ended questions, are helpful. They may feel grief even if the infant is healthy. There's I see a lot of like Instagram reels or something now where they talk about like, is it like gender disappointment or something, or gender, where they're expecting or wanting a certain gender and they don't get that, and they have some mild feelings of sadness over it or grief over it.
Oh my God.
It happens for some people. Huh?
If people don't put their bigger be happy they have a healthy baby.
Right, exactly.
I would probably laugh at somebody, they come at me, I'm just really sad, I'm having a point, I just wanted a girl so bad. Get the fudge cakes out of my face.
But, we're different in size, the kids may be different.
Right.
If it comes out looking like a family member that you're not too fond of, then that could be upsetting. Okay. Stages of the grief process: shock and disbelief, anger, guilt, sadness and depression, and then a gradual resolution of sadness. Okay, if the newborn dies, is stillborn, or has a birth defect, the parent's reactions depend on whether or not the event was expected. If they got a diagnosis during the pregnancy, then they can start that grieving process before the baby's even born. There's some diagnoses that are not compatible with life, so they know, and I think I may have talked about this in the past. There was a young couple that were pregnant with a child that had, he had anencephaly, so he had no skull, like his brain wasn't fully formed, and they knew that he would not survive, possibly even to delivery, but if he did make it to delivery, he would pass shortly after birth. And they had like a little bucket list for him. And they would take her, obviously pregnant belly, and take all these pictures at like the zoo and getting ice cream and going to like a baseball game. And that was their way of, you know, coping and grieving, knowing, but they're in a much different place when that baby's born than a family who has no idea that something may be going on. Right, so you have to kind of keep that in mind as well, like what stage of the grief process are they in. Parents are allowed to progress at their individual pace regarding seeing and holding their newborn. Nobody's ever rushing the baby away. Sometimes parents don't necessarily want to hold the baby, but then after a little bit of time, they change their mind, they do want to hold the baby. So it depends. You evaluate every situation on an individual basis. Every labor and delivery NICU environment has memory packets that we can put together with places for handprints, footprints, locks of hair, if possible. I usually put like a tape, especially if it's like a preemie baby, I'll put like a tape measure in with the length that the baby was, little outfits, hats, things like that. And everybody has phones now with cameras. All right, so care of the newborn. We'll move on to care of the newborn. Admission to the postpartum or nursery unit. If the baby's stable, they're breathing good, their heart rate's good, they transition nicely to being born, then they stay with the mom undisturbed. Vitals can be done while the parent is holding the baby. You don't have to take the baby off the mom's chest to do a set of vital signs, right? You can count respirations while the baby's doing skin to skin. You can get a heart rate that way, and you can check a temperature that way. Okay, so there's no need to disturb the baby right away to do any of that once that initial transition happens. Same with the medications that they get after they're born. The vitamin K and the erythromycin eye ointment. They don't need those right away. They can wait. Let that golden hour happen. That 1 hour of undisturbed bonding time. Okay, so we're going to talk about different phases of newborn care, and it's basically, you know, the first 30 minutes is phase 1, so roughly, these are times of transition, but the first phase of newborn care is right after delivery, and then transfer to the postpartum unit, and then beyond that, or transfer to the nursery, and then beyond that. We're going to skip over, we're going to skip over the phases of transition. All right, one of the biggest things we have to make sure we maintain in a newborn is their temperature. Okay, we talked about this in the past where, you know, a baby that's cold is prone to having low blood sugar. They're also prone to respiratory distress. So keeping them warm is a very simple task that can prevent other problems from occurring. Okay, so supporting thermal regulation. Heat can be lost through evaporation of liquids from the skin. They're wet when they come out, and they come out to a much colder environment than they were nice and cozy in. So it doesn't take much to drop their temperature. Conduction caused by direct contact with a cold surface. Right after they're born, what do we usually put them on? A nice cold scale to weigh them. Although a lot of the beds have scales in them now. So, convection of heat away from the body by drafts. Mom just went through labor and a lot of effort, and maybe has a fan blowing on her. That could ultimately end up blowing on the baby. And then radiation caused by being near a cold surface but not directly on it. Observing bowel and bladder function, making sure that the child voids and stools. They may not pee for 24 hours, and that's okay. We just need to make sure that if they pee at all or they poop at all, that we chart it. So you can't send them home from the hospital until they've done it. They've peed and pooped at least once. Okay? The whole point is to make sure both holes are open and allow for the exit of urine and stool. If they have meconium in their amniotic fluid, that counts, right? Poop came out of somewhere. If they come out and pee all over the mom or the doctor, make sure you chart it because they're not due to. All right, providing for security, we went through a lot of these already in chapter 6, but making sure that they have their ID bands on, their security band that's going to lock down or notify us if the child is brought near an exit or an elevator, or if the band is cut off. It'll alarm and let us know. Some places have certain badges, a different detail on the badge that identifies employees that are allowed to handle newborns. Right, so that somebody from the cardiac floor can't come in and be like, oh, I'm here to take your baby to the nursery. You know, there's something different about the badge. Not every place does that, but some do. And mom is taught to keep the newborn away from the door to the room and not to leave the baby alone. So, you know, if you can put the baby in the nursery while mom showers if she's by herself, or if that's not possible, you close the door to the room and leave the bathroom door open while she showers. Bring the baby towards the bathroom door. All right, evaluating gestational age. Now, most people have prenatal care, and we usually have a good idea as to how many weeks along the pregnancy is when the baby's born. However, for those that don't have prenatal care, there are tools that we can use to kind of give us an idea as to the gestational age if we're unsure. You know, there's also times too where they may say, oh, the baby's 36 weeks and the baby comes out and we're like, I don't know about that. Just with certain appearances and behavior that the child exhibits that may have us questioning the gestational age. There is a form called the Ballard form, which we go over more in chapter 13. And that is a physical assessment that's done. The baby gets a score and it kind of correlates with the gestational age. So we'll go through more of that in chapter 13. You don't have to know the details of it. Some highlights of that, their skin for preterm versus postterm. Preterm infant skin is very thin and transparent, where postterm is healing, very dry and healing. Vernix, the white cheesy substance that's covering babies. Preterm infants will have a lot, and postterm infants will have almost none. Hair, fetal hair, preterm has a lot, postterm has none. All these things kind of go away as they progress through the pregnancy. Ears spring back very slowly, if at all. Very preterm infants, if you fold your ear down like this, will stay there. So sometimes when they're laying on one side for 2 years, their ears like totally flat. Right. For postterm infants, there's in the appearance of male and female genitalia. And then creases on the bottom of the feet. The bottom of a preterm infant's feet are very smooth. They don't have a lot of creases in them. This is a postterm baby. So here's some differences you can see here. You can see this one's got like a little bit of breast tissue there where a preterm infant has none. The skin is obviously very thin and almost translucent. You can't see the feet. But and this one's very dry. They don't have much fat, obviously this as well. All right, observing for injuries or anomalies. Same as in chapter 6, making sure they have all their fingers and toes, check for any webbing of the fingers and toes, cleft lip, cleft palate, spina bifida, you would note that right away, and that would probably be diagnosed on ultrasound before the baby was born anyway. Making sure the facial expressions, movements are the same, are equal. Especially if they used forceps at the delivery. If the child had internal, they have a small on their head on the throat, that's okay. Keep an eye on it, make sure it doesn't get infected. All right, getting vital signs on an infant. Okay, respiratory rate, normal respiratory newborn. Okay, you have to count respirations for 1 full minute because they have periods where they breathe very fast and then they slow down, they breathe fast again. Sure, but what radiant or in isolate, they're going to be connected to a throat. It'll monitor their skin temp because that skin temp is going to adjust the from the warmer. Otherwise, an axillary temp. We don't to the risk of like perforating the rectum is too high. We will do rectal temps like in the emergency room if the child has to go back to the hospital, especially if the fever are. But axillary blood pressure, we use an electronic instrument for that. I will not ask you what blood pressures on an infant because it varies quite a bit. How many days old the baby is, the size of the baby, the gestation of the baby, they fluctuate quite a bit. But we will use an electronic instrument. Cardiac defects can be diagnosed that way. We'll talk about that in chapter 26 when we do cardiac. Obtaining the weight. Babies weighed in the delivery room or when they're admitted over to the nursery. They are placed in their birthday suit on a scale. Weight is measured in grams so that we can calculate safe medication dosages. And they're usually weighed every day, every night. It's a night shift job to get their weight so we can track because babies do lose weight. So we want to make sure we get their weight every night. 3 measurements are done as well: a head circumference, a chest circumference, and a length. Okay, the head circumference is measured right around the eyebrow line, straight around their head. The length, obviously, from the top of their head to the bottom of their feet. And chest circumference is around the nipple line. There can be some fluctuations in the head circumference. Just think about it. If you do a head circumference right after they're born, if it's a vaginal delivery, their head's going to be a little elongated, right? So that could throw off the measurement, the head circumference. So they'll measure it. The pediatricians usually do it, and then they'll do it again before the baby goes home. If they don't like the number the nurses get, they will do it themselves. So let's say. All right, caring for the umbilical cord. Delayed cord clamping is a newish thing, probably within the last couple of years. Ideally, they delay clamping of the umbilical cord for 60 seconds. At the very least 30 seconds, but hopefully 60 seconds. And that helps increase the iron stores going from the placenta to the baby. After that 60-second mark, they can clamp the cord and cut it. We check to make sure the baby has the 3 vessels that we're expecting them to have, right? 2 arteries and 1 vein. Ava, 2 arteries, 1 vein. Some babies only have 2 vessel cords, so they would only have 1 artery and 1 vein, and that may be associated with other abnormalities. Sometimes it just happens. Caring for the cord. The main goal is to prevent infection. Bless you. The longer we keep it dry, the faster it's going to fall off and we won't have to worry about it anymore. So when you're putting the diaper on the baby, make sure you fold it down below the umbilical cord. This is why we avoid soaking the baby in the bathtub, so that that cord can just dry out and fall off and, you know, not be an issue anymore. We don't put anything on the cord to dry it out. Some places used to put like iodine on the cord. We don't have to do that. Put nothing on it, just keep it dry. All right, and parents should report if there's anything foul smelling coming out of the cord or draining out of the cord. Did I tell you guys about the twins with their cord? Did I tell you guys about that last week? No? Quick story. There was a situation in the hospital like a few weeks away because the cord was still like wet and was like oozing something. And here she had twins. The other baby was totally fine, cord dried up, fell off, no issues. But the other one was still wet, draining, not drying up at all. When it starts to dry up, if you've never seen it before, it starts to get hard and like a brownish black color. This thing looked like fresh. So baby comes back to the hospital and everybody's like, oh my gosh, like what is going on? What is happening here? They're trying to put all this stuff on it and to kind of dry it out and nothing's working. And they finally checked and the kid had a track going from their bladder out their cords. He was peeing out of his umbilical cord and peeing in his diaper, but had some urine coming out of the umbilical cord, so it never dried up to fall off. He had surgery to just tie it off, and it was fine. But to tie off the track going from the bladder out, didn't have the like, who knows how long it would have gone on for another baby there, and like, what's going on? One's off, and the other one's not even drying out. Baby was peeing out of it. So if it doesn't fall off, you gotta tell the parents what to expect so that they can report when it's not doing what it's supposed to do. And that's what it looks like on the inside. There are two arteries right here and then one vein. I think I mentioned that before. We can use those for lines. Monitoring for blood pressure. They're nice to have. Without bothering the baby. Glucose below 45. Okay. Pre or post-term infants are at risk for low blood sugars. Babies born to diabetic mothers, babies who are eligible or gestational age or small gestational age. This little chart tells us oxygen or cause some additional stress, then we would could be undiagnosed gestational diabetes or somebody who doesn't have gestational diabetes. So wonder for signs of hypoglycemia. I mean, if we're ever concerned, then it doesn't hurt to check the blood sugar. Lethargy and seizures. They'll almost always have hypoglycemia. A baby will not have hypoglycemia. It's induced by finger stick on tools, everything, but check their heel. Check these little fat pads on the outside of the heel and whatnot on the center part. So you don't want to stick there. You stick a little fat pad on the outside and get a little drop of blood, put it in the machine. Every baby born has a screening test called, the name varies. Some call it the PKU, some call it the state screen, but it's a panel of more than 31 tests that are done on every baby born in the U.S. The mandatory tests vary by state. PKU or phenylketonuria is one that's mandatory in every single state. That should be familiar from A&P, right? PKU?
Yeah.
We'll talk about it again in chapter 14. Okay, these are metabolic disorders, so they can be treated if we diagnose them early enough. Test is done on day of discharge for better accuracy. Ideally, at least 48 hours after the baby's born. Because it's looking for a metabolic disorder, the baby has to metabolize food in order for any of these tests to show anything. So if you do it right after the baby's born and they haven't had much to eat, everybody's gonna be negative. When they have a metabolic disorder, there's something in their, they're not able to like break down certain byproducts of food, like phenylalanine for PKU. And that would show up in the blood and urine, but it shows up in the blood faster. So the sooner we get these done, the sooner we can diagnose, and a lot of times it's just changing the diet to prevent any disabilities from happening. But we'll talk more about that in chapter 14. All right, this is what it looks like. Again, just a little heel stick, just like a blood sugar, and color in the circles here on this piece of filter paper, and it gets sent off to the state lab where they do the tests. They'll look for cystic fibrosis, they do sickle cell, hyperthyroid or hypothyroid, problems with the adrenals, what else? Maple syrup urine disease.
Mm-hmm.
That's the thing. All right, promoting bonding and attachment. It's going to take some time for mom and dad or whoever to learn the infant's cues. Right, the longer you spend with the baby, the more you learn which cues are for hunger, which ones are for wet diapers. Nursing assessments include observing cues to occur. Some parents are not able to bond with their child for whatever reason. Social work's great to assist with anything that might be going on that might impact the parents bonding with the baby. Things we can do to help promote bonding and attachment: call the infant by name, holding the infant face to face, making sure we do skin to skin contact with the mom, and talking in gentle, usually your baby voice. Gentle, high-pitched tones. And here's lots of skin to skin here. I like this one with the brother there holding one of the babies. But anybody can do skin to skin. It's usually the mom, but dads do too. Grandmas, I've seen grandmas come and do it. Siblings. Okay. Pause here.